So before I begin, I'm going to just explain a little bit who I am, what I do, and exactly why I'm talking to you tonight. So as was mentioned, I am a hospitalist at Cornell, which is an internist, a practitioner of general medicine, and I see people who are admitted to the hospital. For example, if someone has chest pain or they have a bleeding ulcer or they have some sort of infection requiring IV antibiotics, so then I'm the doctor who takes care of them while they're in the hospital. And then after they get discharged, they go back to their community doctor. And unfortunately, with the new disease, with COVID, so we ended up taking over, it took over our hospital, and we became primarily people who took care of COVID patients. And so that basically gave me a perspective of that's different than what many people have. We share a lot of the same information. We get a lot of the same, stuff from the news, from Dr. Fauci, from the governor, from all sorts of inputs. Yet I have to take that information and process it so I can do my job. And so basically, when Leon asked me to talk tonight, I figured that it would be helpful for everyone, for you guys to maybe get my perspective. And so therefore tonight, what I'm trying to do is share my perspective of how I process the information that we were getting and how I was able to take that information and change my clinical thought process and be able to take care of people who have COVID-19. And hopefully that process, you will be able to improve your insight when you process the information moving forward. So before I continue, I would like to thank every one of you guys and everyone who is participating tonight in this talk. So what are we going to talk about tonight? The first thing we're going to do is just some common terms that we're all familiar with. We'll go over some background. COVID didn't just start in a vacuum. You'll get my perspective. We'll try to wrap things up. And then finally, at the very end, whoever has any questions, feel free to submit them via the chat to Leon, and he'll present them at the end, and we'll try to have some time at the end to go over questions. So what are some terms that people like talking about? So I hope that none of these terms is new for you. So everybody likes SARS-CoV-2. That's the actual name of the virus. It stands for, actually, we're just gonna leave it at SARS-CoV-2. It's a coronavirus. COVID-19 is a disease caused by the infection of SARS-CoV-2. Hydroxychloroquine is the medication that everybody was talking about at the beginning. People are still talking about it. I'm not going to tell you whether you should take it or you shouldn't take it, except for the fact that the data does not support right now taking it. So it's not something that I would generally offer. Maybe there's some instances that it may be helpful. But at this point, that's something that was on everybody's mind at the beginning. Is this something that works? Finally, there's the medication remdesivir. This actually has been a game changer. If I'm not mistaken, the data is about 60% of a improvement in survival from this medication. So that's something that totally changes the picture from where we were in March and April and where we are now on the other parts of the country who are going through the spike. Finally, we had the IL-1 and IL-6. They're the interleukins. This is part of all the inflammatory response that the body wreaked havoc for the people who are really, really sick. We have the RT-PCR, that's reverse transcriptase. This is what the fancy name for that nose swab that everybody would get, or still gets. It's the way to take the RNA of the virus material, that's the building blocks of the material. And it's a lab modality. It's a way for them to increase it to a tremendous number so that it can be detected by the machine. And so it takes whatever virus you have and it amplifies it. It makes it grow really, really fast, and then it detects it. So it's a reverse transcriptase PCR. It's a very fancy test, but it's able to tell whether somebody actually has the genetic material of the virus. What it can't tell is whether somebody is actually infected. We have to use our clinical judgment combined with the test, because there are things like we talk about sensitivity, specificity. Is it a false positive, meaning the person came back, it was a positive test, but they really don't have it, or a false negative, they really have it, but the test came back negative. It also depends on how early we get the test. So somebody who was just exposed likely doesn't have enough virus to be able to swab positive at that point. They need a couple of days, probably about 4 or 5 minimum, to get at least a 50–60% chance of having a positive test. And then moving forward, a problem of repositives. That's something that came out of South Korea, which was somebody who had COVID, tested positive, then tested negative, means that they were cured of it. And then a couple of weeks later, all of a sudden they swab positive. So there's a thought, were they reinfected? Are they not reinfected? So that's an ongoing study, but right now we call it repositive. We don't call it reinfected, because, as I said, it's just genetic material. It doesn't tell us whether you actually have a live virus. Then the other thing that everybody became an expert on is the antibodies. That's the body's reaction to an infection. And we all, anybody with a working immune system, at some point will develop antibodies, and then there'll be memory cells, so that if you get re-challenged with that infection, your body should be able to fight it. Question is coronavirus, is this COVID-19 one of those diseases where your body will remember it and you won't get it again, because as soon as the body senses it, it will kill it off? Or is it something like the common cold, which you'll just get every single year, but your body will be able to fight it off with its memory? So that's the question right now, for, what we're trying to figure out. And so therefore, when people talk about antibodies, I kind of laugh, because it really doesn't tell us much in terms of whether the person is protected. However, a good antibody response means that you probably were infected. And if you were infected, good chance, at least now, that you're somewhat protected. So we'll leave it at that. The most important thing would be again, if you really want to know if somebody's infected, symptoms plus a positive swab, or somebody who has been exposed and a positive swab. And finally, everybody loves talking about herd immunity. Herd immunity is a theory. It is not a fact. It's something that we assume if you get enough people who've been infected or have at least antibodies, that the disease cannot spread. That's something that we know for, with mumps and measles. You get enough people with antibodies, then those diseases pretty much are eliminated. But as people stop getting vaccinated or stop having antibodies, so then the disease pops back up. And so now the question is are certain locations have herd immunity? The bottom line is nobody really knows. We do know that people are losing their antibodies the less they were infected or if they were asymptomatic. So these are all technical terms, but people like talking about it. I sort of think of it as like me being a meteorologist and talking about polar vortexes and stuff like that. And finally, we have the big deal, which are the super spreaders. Those are the people who, it only takes a few people to get a lot of people sick. And that's something that we found for this, for COVID-19, is that it's not that if one person gets sick, they're automatically guaranteed to give it to somebody else. It's usually what ends up happening is one person ends up infecting a couple of dozen people. We've had several cases, and I'll show some illustrations later on of how one person ends up infecting a lot of people. So that is basically the terms that people like talking about. And for probably what I've just said are stuff that you've all heard about. And it's sort of, we're all tired about talking about that kind of stuff. But anyway, I want to give you some of my background in terms of not so much my background, but my thought process in terms of how I started approaching COVID when it came out. And as a disclaimer, I didn't believe that this was going to get people very, very sick. For crying out loud, it's a coronavirus. We have coronaviruses all the time. It's the common cold. I have a book called Making Clinical Microbiology Made Ridiculously Simple, and it has a nice cartoon on the back of it with a rhinoceros drinking NyQuil and holding a Corona in his hand, in his other hand. And so basically that was to remind us that the common cold is caused most commonly by rhinovirus and coronavirus. So there's a bunch of different kinds of coronaviruses, and I thought that, okay, it was getting people sick in China, but we're pretty much okay. And then all of a sudden, as everybody over here knows, it wasn't okay, and it's not okay. And so how does somebody who's a doctor, how does a scientist, how do they approach a new virus? As I said at the beginning, viruses don't come in a vacuum. So we take information that we do know and we apply it to be able to figure out what we don't know. And so the background that pretty much everybody in public health, and whenever we talk about public health, usually starts something with this guy. This is Dr. Ignaz Semmelweis. He was a doctor in Vienna, and we'll talk about him in a little bit, but he is pretty much considered the father of infectious control practices and mainly washing your hands. We'll talk about him. So this is Ignaz Semmelweis. And then finally, this gentleman on the right-hand side is considered the father of modern epidemiology. This is Dr. John Snow. And if Dr. Semmelweis, he was an obstetrician, Dr. John Snow was an anesthesiologist in the 1800s. Both of them were in the 1800s. And Dr. John Snow, is his major claim to fame, besides being the father of modern epidemiology, is he was the one who anesthetized Queen Victoria on her 8th and 9th children, which was at that time something that nobody ever heard of. And that led to the anesthesia being part of giving birth. So all the women who are listening and had an epidural during their labor, they can thank Dr. John Snow for breaking that barrier. But we'll explain why he's important for infections. And then finally, this is Dr. Li Wenlong, and we'll talk about why he's on this slide. So why was Dr. Semmelweis important? So he was, as I said, an obstetrician. He was a doctor in Vienna, and there was 2 wards. There was the first clinic and the second clinic, and the one was run by the doctors and the medical students, and the other one was by the midwives. So the top one is the infection rate in the doctor's clinic, and the bottom line is the infection rate in the midwife's clinic. And what he noticed was women were dying at a much higher percentage in the doctor's clinic than the midwife's clinic every single year. And he couldn't understand why, until he finally realized that the doctors were going from the autopsies of the women who were dying and then going and delivering them in the hospital, and they didn't wash their hands. So he came up with the idea, and this is before germ theory. This is before anybody knew what a microbe was, before anybody knew that this was actually caused by streptococcus infection. He introduced chlorine hand washing, and this was in 1847. And all of a sudden, the mortality rate, the death rate of the doctor's patients ended up matching exactly to the midwives. And that was all from chlorine hand washing. I would love to say that he was hailed as a hero, but he actually was vilified by his colleagues because they said this was ridiculous. A gentleman's hands are clean, as one of his colleagues said. He ended up being vilified by his colleagues. He went insane. He was put into an insane asylum, and he actually died from an infection. Only afterwards was his contribution to medicine recognized. But the point that I really want to make out of this is that they didn't know what was causing the infection. But through observation, he was able to figure out an intervention, and that intervention saved a lot of lives. The next person that we see is John Snow. There was a cholera epidemic in the 1850s, and I know this is you can't really see it, but he took a map of London, and here's Broad Street, Piccadilly Circus, Regent Circus over here, Piccadilly is over on the bottom. And he noticed that a bunch of people where all these blocks were dying from cholera, but nobody on the north over here were dying. And he recognized that there was a pump on Broad Street, a water pump. And he thought that maybe this pump was that something in the water was causing the infections below it. And so everybody who was using this pump anybody below the pump who was using that water was getting infected, and everybody who was using other water was not dying, was not getting cholera. It turned out as a bacteria, Vibrio cholera, which nobody knew again in the 1850s, the whole idea of an infection. Yet he figured that out, and he did a simple intervention. He took off the pump from the handle, and the epidemic stopped. Again, he was originally ridiculed by his colleagues. They thought the infection was caused by miasma, but at the same time, he recognized that there was an issue. Through observation, he figured out something that was wrong, and even though they didn't really understand why, he was able to do an intervention, and that intervention ended up saving lives. Which comes to Dr. Li Wenliang. Dr. Li Wenliang is a doctor in Wuhan, China. And as people know, that on December 30th, that's when the Wuhan CDC issued a local warning about this mysterious pneumonia that was going on in China. And he was in the hospital, and he got the internal report. And when he got this internal report, he shared it on WeChat, which is a private messaging service, with a bunch of his friends from medical school. And he begged them, please don't make this public. But his screenshots got leaked out to the Chinese internet. And so on January 3rd, the police censured him. They actually called him down into the police office, admonished him, made him sign a letter that he was wrong for publishing untrue statements about 7 confirmed SARS cases at the Hunan seafood market. Unfortunately, he was an ophthalmologist. And one of the patients that he was treating for glaucoma had SARS-CoV-2, had the infection, had COVID-19, and he contracted COVID-19 on January 7th, admitted to the ICU on the 12th. He realized that things weren't going so well, experienced on social media, within the police station, and his letter of admonition. That was on January 31st, which led to the world basically questioning why people were suppressing the doctors who were figuring out what was going on in the hospital, because they were getting this mysterious pneumonia. And unfortunately, on February 7th, he dies from COVID-19. He was 33 years old. And he was the first of 6 Wuhan hospital doctors to die from COVID-19 as of last month. So we just went through some of the background of basically, let's observe. Even if we don't know, if we observe and follow some basic infectious control principles, we can get a handle on an infectious disease. And so that's the next thing that I want to talk about, is that we learned how from these doctors how you can approach a public health crisis. And pretty much it all comes down to a chain of transmission. You need to have the infection, that's the bacteria, or in our case, the virus. You have to have people or a source for this infection, that's the reservoir. It has to go from the reservoir and somehow get into the person who is going to get sick. So you have the reservoir where the infection is, somehow it leaves the reservoir, it gets transmitted either through a contact, meaning you touch it, a droplet, somebody speaks or sneezes. Airborne is like tuberculosis, where it just stays in the air. And then it has to enter the other person and start replicating and causing that person to get sick. And so these are all different kinds of things that make the person susceptible. The main thing is if you don't have immunity, that's the equivalent of being immunosuppressed. And with COVID-19, that was the problem. That is the problem. We don't have immunity. So since we don't have immunity, we're going to get sick by this. And it's a perfect storm of a virus. It's just enough infective, and it has enough infectivity to be able to get a lot of people sick, but it's also deadly that it kills people. So anyway, how do we fix that? This is a standard practice in infection control, is you break the chain in any kind of way you can. So either you kill the actual agent. If it's a bacteria, you can kill it with antibiotics, hopefully. If it's a virus, you disinfect or sterilize. And then you try to make sure for the reservoir, you do all these kinds of controls. The exit, again, you can wash hands, make sure you get waste gets put away properly. And then you try the modes of transmission. So for our case, it's called we're going to talk about how droplets spread and things like that. You separate people, you get distance in between people, and that can break the modes of transmission. Ports of entries, you limit the ability for the virus to get in. So one of the things that we do is we wear a mask, or we wear face shields, we wear different kinds of, we wear different ones. I basically wear scrubs now. I used to wear regular clothes to the hospital, but now I wear scrubs all the time and change before I come home. These are trying to break the chain. And then finally, to make sure, either we figure out how to treat it, or we somehow we can come up with an immunization. That's the last thing. So at all times, we just try to break the chain of infection. And we were studying how can we break the chain of infection for COVID. And I have to say, like the governor says, New Yorkers did a great job of breaking the chain through distancing, masks, and all that kind of stuff. As a collective group, we did a tremendous job, and you can actually feel it once the tide started changing. And I hope that that could be the same thing for the rest of the country. So moving on to other aspects of how I interpreted the data that was coming, this was an interesting article that came out. Now, if you notice that over here, it's an accelerated article preview. These things were flying into my inbox every day in terms of people were just trying to publish as quickly as they can. Now, it doesn't necessarily mean that it's the best kind of data, but that was one of the things that we had to do. We had to take this information and figure it out on the fly. And of course, we always put it into a level of risk. I'm reminded of the lawyers who came down when I was in medical school to teach us about malpractice. And actually, I think it was residency, not medical school. It was in residency, they came down and they said, lawyers always, and I hope I'm not offending any lawyers and I hope I'm not offending any doctors. This is the story, so I'm just going to share it. They said lawyers want things in black and white. Is it yes or no? Did the disease cause the patient to die or not? Did the medical error cause the patient harm or not? And doctors are a level of risk, or a level of likelihood, it's probability. We can never say with 100% certainty pretty much anything. And so therefore we want to say, yes, there are different ways to get COVID-19, but is there any way that's more likely or less likely so that we can focus our efforts, or at least from my perspective, focus my effort on trying to minimize what I can and just hope that that's enough to be able to break the chain so that we can, people can be healthy and move on. So this is one of those papers in terms of the analysis, the aerodynamic analysis of SARS-CoV-2, which basically in English means that how does COVID-19 fly through the air? And this was something that came out, and we took this, and you probably heard information on the news that was based on papers like this. Number one, they found that in isolation wards in the ventilated rooms, you had low levels. The highest levels were found in the toilets. And that's the reason why people have been saying, and I was telling patients and family members and all sorts of people, avoid public toilets. That's one of the areas that are high levels of where you can catch it. You can touch it. It's something people, it's not the cleanest place. And the other thing that they found was that most of the public places did not have a detectable virus. So you couldn't find the virus there, except if there was areas of crowding. So this again points to, if you're in crowding, you're likely to have an increased risk. And that drives the recommendations of staying away from people, social distancing. However, as they point out very clearly, it doesn't tell you who's going to get infected, why somebody gets infected, how somebody gets infected. So, but it does give a sense of where a person can get infected. And so therefore, if I would have to say something on this, I would say, okay, stay in public places, avoid crowding, and avoid public toilets. And that would be something that came out from a study. The next thing that I'm going to show you is, some of you may have or may have not seen it. I hope it comes out, but it's an example of how COVID-19 can get all over the place. It's a demonstration. It is not the actual virus, and it's not 100% that we can say that this is a high level way of transmission, but it's definitely fascinating and eye-opening. So we'll just wait for it to load up. It is supposed to be blue. So we have a person who gets fluorescent paint squeezed onto his hand, It gets shown up on a light. They then share a buffet for 30 minutes. They sit down and they talk. And at the end, they turn on the lights and they look where the fluorescent paint is, and it's all over the place. It's on people's hands. So this has started from one person's hands, and now it's on her napkin, it's on her mouth. 3 people had it on their mouths, and they found out that it was the main culprits were the serving utensils and the serving utensils and the pitcher of water. So it just goes to show that was a 30-minute buffet, and that paint was all over the place. So if we can just conjecture, if we have something that gets spread through contact, that within 30 minutes without proper hand hygiene, without proper washing, it's all over the place. And that was one of the things when it was discovered that you can contract COVID-19 by touching, in fact, places with that the virus was living, that you could spread it. However, I do have to put a caveat. We do know now that it's not a major way of spread. Droplet spread is a much more significant way of spreading, and we will, and that we'll talk in a little bit. But before we talk about that kind of spread, I want to come back to the super spreaders. This was an idea, people may have heard of the R naught, that's the R with the little 0 next to it. And that's, everybody says if it's above 1, that's dangerous because that means that one person can spread it to more than one person, and the virus will escalate out of control. Our goal is to break the spread of infection by getting that R underneath 1. So that's the big idea. However, as was explained to me by a couple of infectious disease doctors, and the papers that came out, it's not necessarily that it's a one-to-one transmission rate. We do say that the R naught is, let's say, 1, and it will cause spread. However, what we find with COVID-19 is that it was much more likely to be caused by super spreaders than, so a few people infect a lot of people as opposed to everybody infecting everybody. Question is, how do you catch a super spreader? It's pretty much impossible. So we have to assume that people are super spreaders. And that is the reason why a lot of the practices are in place of social distancing, quarantining, and things, and the like, because most likely the super spreader will be somebody who does not have symptoms. So I give you a couple of the cases. These are from the MMWRs. That's the weekly morbidity and mortality reports by the CDC. The first one was the choir practice that you may have heard of in Washington State. That was one person, they had I think it was an hour or so of a choir practice, and a bunch of people got sick and 3 people died. Then you had this case in Chicago where a person was in, I believe I have that in a future slide. Yeah, I have in a future slide. I'll get to that in a minute. But the case in Chicago, person went to a funeral. The super spreader went to a funeral. The next 2 days later, he went to a birthday party, and he spread it. So that showed how a super spreader spread it. We had the case in New Rochelle in New York. There was the case in South Korea where a guy went to 3 bars, and he ended up infecting over 100-something people. So the super spreaders are a big deal. This is like an example of what happened in the nursing home in King County, Washington State, which was one of the first outbreaks in the United States. This is a case of, they were able to map out how when people were sick or asymptomatic with no symptoms, pre-symptomatic before they got sick, maybe they had a little sniffle, the symptomatic, but they had like diarrhea and other kinds of symptoms as opposed to the cough, and then the typical symptoms. And these are the what in terms of how much of a virus they had. But so these are the technical slides. These are something that if I would be giving a talk or somebody's giving a talk, they would put up and explain to us how things spread. And it leads to this kind of table in terms of everybody knows the list of symptoms. Well, where do we get it from? We get it, again, coming back to those original principles. Let's look at what people who are getting sick. And now you have all the kinds of characteristics. Those who were negative, those who were positive, you see the fever, the cough, and those are the shortness of breath, those are your typical symptoms. And then you have the atypical symptoms where people are just like tired, they're nauseous, confused, they may be dizzy, they have the diarrhea. Runny nose was funny. That was considered an atypical symptom. We do know now it didn't make it on this list, but it was the loss of the sense of taste and the loss of sense of smell that came up. That made it into our review of systems, how we asked people questions. So these were the things that we were trying to do so that when somebody would come into the hospital, we would start asking these kinds of questions and getting a sense of, are we dealing with a COVID case or not, especially at the very beginning when there wasn't a lot of cases coming in. So those were the symptoms in the nursing home. And then finally, this is the spread. This would be the way that they would describe the spread of the super spreader. That's A1.1. He was at a meal and then a funeral, and there was two different families. So the first one was the meal and the funeral. He got those people sick. This is from day 1, and this is how many days after people were exposed that they got infected. And then on day 5, he went to a birthday party and infected a whole bunch of other people, or probable. Probable just means that they didn't swab them, but they had the symptoms that were concerning. And what was really sad over here is that he got 3 people sick, and those 3 people that got that were hospitalized, those are the gray, they ended up dying. So this one person unfortunately infected all these people, and 3 people died from one super spreader. I can't imagine having to live with that kind of knowledge, but that was, and he was asymptomatic or at most pre-symptomatic on day 1. So it goes to show that we have to be careful about spreading our droplets. I like this slide a lot. I think my wife also likes it. I hope you like it too. Because now we're going to go to the main thing that people what scientists we've discovered is that primarily COVID-19 is spread through droplets. So you need to be able to have a droplet spread, and that will be the primary way somebody gets COVID-19, that it gets transferred. It doesn't necessarily mean that somebody will get infected. That has a whole bunch of characteristics that we're still working out. However, the primary transmission is droplet. So when somebody speaks, you can't even see the droplets coming out. So there's a couple of ways of being able to see the droplets coming out. Like when I'm talking right now onto my computer, millions of droplets are coming out, and my computer now is covered with droplets. They did a study where the next slide is going to be the video of this study. This was in the New England Journal of Medicine, where they used laser light to show the spray of somebody talking at different levels, low level talk, mid level talk, high level talk. And as they were talking, you see on the screen the laser just shine up with all the droplets. This is just to show how much droplet is generated by normal talking. And so right now you're going to basically see a black screen. You're going to have 2 people talking. One person is going to be instructing the second person, and as he talks, you will see the spray from the laser light. And it's going to be, the first half is going to be with him talking without a mask. And then his second one is going to be talking with a regular wet cloth or a regular mask. Okay, so let's see how that goes.
Stay healthy.
Great.
Stay healthy.
Great. Less loud.
Stay healthy. Stay healthy.
Louder.
Stay healthy.
Louder.
Stay healthy.
Okay, so please everybody stay healthy. And we see direct evidence of how mask decreases the likelihood of droplet spread. So, but I do know that most of the crowd listening to this, I've been told, are very, very conscious about wearing masks. So this is some proof for you, although it's probably not going to be worth getting into any kind of argument with somebody who doesn't wear a mask, but at least you will know to stay away from when they're talking or coughing or sneezing. Try to put them behind you. Try to put them in front of you, away from you. Because if you did notice, almost all of the spread was in front of him. Very rarely does it go behind him. Anyway, again, coming back with the idea that it gets spread with droplet, we did see a little bit with contact and close quarters. In this situation, this is a case of where there was a fitness dance classes in South Korea. And what they had was a workshop on February 15th, which a bunch of instructors went to, and then those instructors went to various other facilities. In the end, from February 15th to March 9th, so about 3 to 4 weeks, over that time, 112 people were infected from the original infector, which was one fitness instructor, and got 112 people infected at 12 different sites. So we see, number one, how it spread through droplet. We see how it got spread through close contact, and we see how it got spread over multiple venues because they were just in contact. And so this is one of those kinds of slides that just illustrates to me how I have to explain to people that just because today you were okay doesn't mean that you weren't around somebody who was in a venue like this. However, as I come back to the original one, I put this into perspective. I put it into a risk stratification, and I hope the next slide can help that. So this is where it came out, where they had a case of people eating in a restaurant in Wuhan, in Guangzhou, China, and this person A1 is the one who was the person who was sick, and all these other people were the ones who got sick from these other tables, and he was just at this party, and it says the dates when they got it. So he was sick on January 24th, and then you have spread throughout to February 5th. But notice that the people to his right, I assume that he's facing this direction, those people facing to his right did not get sick. And the idea was that the air circulation, the current, helped direct the spread away from other people. So ventilation becomes a big deal. So here was where you had the air conditioner blowing across the table. So somehow it got these couple of people sick. It's not 100% clear how, but we see how ventilation can change the spread of disease. It can actually get other people sick, and it can also help prevent another person getting sick. And that comes to a study that, again, one of the infectious disease lectures that I listened to brought this study up. This is a study that was in 2007, which was talking about natural ventilation versus mechanical ventilation. That means a window versus a machine generating the ventilation. And it concluded that this was in Peru, and they had old-fashioned hospitals with high ceilings and large windows had a better ventilation rate than the mechanically ventilated negative pressure room. The specific one was 28 air changes per hour in the high ceilings, large windows, versus the 12 air changes in the negative pressure mechanically ventilated room. This is in terms of tuberculosis, which is an aerosolized disease. That's you can be in the same room and be several feet away, much more than 6 feet, and catch tuberculosis from somebody who has tuberculosis, because it is an aerosolized disease. However, it did show how ventilation in and of itself can help improve it. And that is how this is where people had said, crack open up a door, open up the window, help get natural ventilation. It can help. Obviously, we're not going to do that in the hospital when we have to use mechanical ventilation. So we require the PPE that everybody talks about. So the final thing that I wanted to talk about is, where did the 6 feet come from? Because that's something that everybody wants to know. Where the 6 feet, where did it come from? And it's very, very interesting. And that's the next slide. The actual original data is from 1934. There's a person by the name of Dr. Wells came up with idea of how droplets fall. And if you notice that as somebody talks or sneezes or coughs, there's a spread and then it falls, and how much they spread, how long it goes, what's the distance. So I'm going, just for our American friends listening, this is in meters. A meter is 40 inches, which for our purposes will round it to 3 feet. So when they saw in just normal talking, almost all the droplets drop before 1 meter or before 3 feet. And some of them get aerosolized, but not a lot. So in normal talking, pretty much after 3 feet, you're protected. Obviously, 2 feet is even better. 2 meters or 6 feet is even better. And so therefore, this is where the 6 feet came from. However, that is only in terms of normal talking and normal breathing. If you have somebody coughing, that already gets you out to 3 meters or 9 feet, 9 to 10 feet. And if somebody actually sneezes and they don't sneeze into their elbow, that can go all the way out to 6 meters, almost 7 meters. So this is the idea of, this is a person without a mask. So you put a mask on this person, and that it ends right here. So this is where we came to, I wear a mask for you, and you wear a mask for me. So again, I'm preaching to the choir over here, but if somebody wants to know what's the data behind it, these are where the data come from in terms of, it's a droplet disease. How do you protect the droplet disease? You cover it up, spread yourself, get some distance away from each other, and at the end of the day, make sure that you don't convey it to other people and convey it to yourself by washing your hands. So those are the 3 things that everybody's been told about: socially distance, wash your hands. And here's some of the data behind it. But there is one, like the medicine and the science, but there is one more term, and that is something called COVID fatigue, which I wouldn't be surprised if most of us actually have it. I have COVID fatigue. I'm exhausted about talking about COVID, having to stay home when not walking around when we did it for months, although now I'm much more out and about wearing a mask, trying to stay socially distanced. And again, not being able to be part of society. And it's exhausting. And not only is it is exhausting, it's very stressful. And the stress comes both from just the idea of it, but also the uncertainty. And I saw a recent article by a psychologist in UC Davis, who she summarized it. Her name was Dr. Kay Hermanson. And she basically wrote about COVID fatigue, which even if we don't give it a name, I'm sure people can feel it. And she gave some tips and tricks to be able to overcome it. Basically, we have to learn how to cope with COVID-19. And a lot of us have done that, but I don't know exactly who's listening in right now all across the country. You know, in New York, we went through it for 2.5, 3 months, and it was not pretty, to say the least. And even now, being the fact that it spreads throughout the country, it's now sort of rearing its ugly head, and we're kind of like tired of it. So how do we cope with it? So the first thing is that she says, recognize it. Recognize that this exists. If you recognize that it exists, so then we can deal with it, we can talk about it. And that's healthy, because when we can talk about and recognize it, it's know thy enemy. That's the first point. The other thing is coping skills, getting exercise, even if it's just a simple walk. So of course, there's nothing stopping a person from walking. You just want to wear a mask if you're going to be near people. And if you're not going to be near people, so then you could walk without the mask. Talking about it is very helpful. Thinking positively and thinking about that I can only deal with what I can deal with. I can only do with what I can do, and not perseverating and not thinking too much on the things that I can't do, and sort of just realizing that and taking it a day at a time. The other thing is that we're so inundated, we're saturated with information and news and warnings and numbers. At some point we have to take a break, but we can't take a full break because this is important. We are in a public health crisis. So she recommends limiting it to a simple trusted source, and pretty much staying off social media, and definitely avoiding arguments with other people, because you likely we're not going to change anybody's mind. I'm not going to change anybody's mind, and very likely most of the people I'm talking with are not going to be able to change other people's minds. Sorry. Sorry about that. And finally, she ends off, and I'd like to end off with this. She says, I remind myself to control the things that I can and that I can't control other people. I say to myself, for every person not masking, look at all the people who are, which is basically the idea of we're in it together, but we have to be responsible ourselves. And I'm sure, I'm talking to a responsible group. And so I hope that this is helpful for yourselves, that it gave you a perspective, that you're able to get a perspective from me in terms of how I took the information, a lot of the information that you were getting, and put it into a context that I can deal with. I do realize at the end of the day, and I hope everybody realizes as we deal with this fatigue, that COVID is not a righteous disease. It's you can do everything right and still catch it, and people can be total infectious control fools and not get it. But that's not the point. It's that there are tools that we have in our toolbox that are been around for a couple hundred years on how to deal with it. Washing hands, covering our face, even if we don't know something about it. So with that, I would like to end and say thank you very much for joining me tonight and sharing my perspective. And I turn it back to Leon.
Thank you so much, Dr. Lehrer. These information was for sure enlightening. Would you have a couple moments to answer some questions what we got in the chat? People wanted to ask a few questions.
Sure.
Sure. So I have one listener here is posting regarding the super spreaders. Is there anything specific that makes someone a super spreader, or it's just about how many people they come in contact with?
Good question. So that's a two-part question. The first one, is there anything about the super spreader that makes them more likely to be a super spreader? And then the second question is it the number of people that you get in contact with? So we'll separate out those two questions. The first question is there's definitely something about super spreaders that make them more likely of spreading the disease to other people. Exactly what that is, not known yet. So we just know that it exists. So that's the answer to the first question. It exists. How, why? Unknown right now. In terms of the number of people, they can have the same number of people that a non-super spreader will meet. And it's the super spreader will just have the same, will get more people infected. So there's something about either the viral load or something, the characteristics of the super spreader that will cause the person who's on the receiving end to be more likely to get infected.
Thank you. I'm getting here another question from a listener of what's the safe way to interact with others, as well as someone would like to know what does the doctor feel about, I guess, play dates for kids and how to do so in a safe way.
Oh, excellent question. So how do we interact with others? Be as social as you can, be kind, gentle, listening, patient. I say that to myself all the time. That's how we interact. In terms of being able to, in terms of being able to, how should I say, be like we used to, that's something that we have to pause. There is a thought that we did get out from, that we can take from New Zealand, where they sort of buddied up. We do know that there is there's this concept of people in your own bubble. So people who quarantine together, so they're just basically sharing everything. So it depends on if the person's not sick, you can try to expand your bubble a little bit. Can I say that I'm advocating that? I can't say that I'm advocating it, that I think that it's a great idea, but we also have to realize that there's a mental toll taken by COVID-19. And if that's something that you can do safely by expanding your bubble So then that's something that may be an option. And getting to the second question of daycare and play dates, I know that people were scared about the multi-inflammatory disease that kids were getting that thankfully is very, very rare. But, and kids generally speaking are safe. Kids are the time when we can teach them good practices. That's good practices start from really, really young. So if we can get them, they'll be much more likely to be able to wear a mask properly if you teach them properly, as long as it's safe. And they're much more likely to wash their hands properly if you teach them how to wash their hands properly. So play dates is, again, it's something about creating a bubble for yourself. It's different in different areas. I want to put a caveat on all this. This is obviously in places with low levels of infection. If you're already going to be in a place that has high levels of infection, I guess we'll use New York, New Jersey, Connecticut's 10% as a cutoff. Be much more careful about expanding your bubble. I'm talking about, let's say, like in New York, where it's pretty much like 1%. Stay away from the people who are coming from out of state, from high infective places. Again, make sure that everybody's in your interactions wearing a mask, then that seriously decreases your risk. So to sum up this answer, you can cautiously expand your bubble in a safe way with people in low risk areas. And in terms of play dates, it's try to do it safely.
Sure, and two last questions. First, someone would like to know regarding, do we have clear information about the different strains of COVID-19? As well as, is there anything what people other than masks to take to prevent themselves? If there's any vitamins, anything like that?
Good questions. So the first thing in terms of strains, so we're dealing with a virus. A virus is genetic material in a protein cover, and it doesn't have its own cell. There's a whole question whether we even consider whether it's alive. It requires a person's cell or an animal cell to replicate, to make more virus. And so, and it does this millions and millions and millions of times. When you replicate something that many times, there are going to be changes in it. It's going to change the protein here, a little protein there. Errors will creep in. That's how you get strains. And to answer the question regarding the strains, that's what the scientists are looking at. That's how they can tell which strains came from China, which strains came from Europe, which strains come from New York. And they know where, then depending on the strain, they can sort of make the determination of whether it's effective or less effective, is it as deadly or less deadly. But that's going to, that takes some time to play out. But the strains, that's something that the scientists just look at.
Okay, thank you so much everyone for joining. If there's any more questions, they could submit it to myself, or they could go online, I believe, to Cornell Medical Center, so to have information of how to contact Dr. Moshe Lehrer, if necessary. If we'll be okay with that. And I appreciate everyone joining. Again, want to thank once more Dr. Moshe Lehrer, and wish everyone a happy and safe summer. Thank you very much all for being here. Have a good evening.
Thank you very much.